So today's topic is chemotherapy in carcinoma stomach. So gastric cancer is secondly cause of death from the malignancy worldwide, though it's not that much common in India. Almost 1 million people develop the disease, more than 7 lakh people die from the tumor every year. But the highest incidence is reported in East Asian countries like Japan, China, Korea, and other like South America and Eastern Europe. So multimodality treatment is ideally that with surgery, chemotherapy and radiotherapy in combination has shown to improve results compared to just surgery alone. It all depends on where it's commonly practiced. Like in East Asia, surgery is commonly followed by long-term chemotherapy. Europe, they used to give perioperative chemotherapy, and US, radiotherapy is more preferred rather than chemotherapy. So what's the rationale for giving perioperative chemotherapy? In most of the countries, majority of the patients are diagnosed in advanced stage, except for like Japan, where there is extensive screening to search for patients in early stage. So about half of them can be curatively resected, but even with R0 resection, the 2/3 will still show recurrence within 2 to 3 years. So just surgery is still not enough. We need to give some other sort of treatment, either neoadjuvant before surgery or adjuvant after surgery. So therefore, adding this treatment increases the resection rates, disease-free survival, and overall survival. One of the first study which showed this benefit was the Famtex trial, 2004 Dutch study, in which the patients were given a Famtex chemotherapy prior to surgery versus surgery alone. But it didn't show that much benefit, but it showed a trend towards benefit. So this is one of the pivotal trial which established the role of perioperative therapy in MAGIC trial. In the patients 2006 trial, in which they gave 3 cycles of ECF followed by surgery and then 3 cycles of ECF versus surgery alone. There was significant improvement in overall survival, 5-year survival rate, as well as disease-free survival in these patients. And this benefit was seen in all the patients, like irrespective of age, where the site of primary tumor is there. So it was definitely established based on this that we have to give some sort of perioperative therapy. This is one of the other trial, FNLCC Accord 07 trial, in which had 75% of patients had adenocarcinoma of distal esophagus or GE junction, in which they gave a neoadjuvant chemotherapy of 2 to 3 cycles of cisplatin 5-FU. And after NACT, the R0 resections were significantly higher. As in the MAGIC trial, only 50% of the patients were able to get the full chemotherapy in this trial. But the disease difference in 5-year survival as well as 5-year disease-free survival was significant at around 14%, which favors that neoadjuvant therapy should be given. If we cannot give neoadjuvant, then there is a rationale for adjuvant therapy as well, because despite radical surgery, patient will relapse. So if we cannot give therapy before surgery, then we have to give some sort of therapy after surgery as well, because it depends on multiple factors what kind of surgery has been done, D1, D2 resection, whether extended lymphodectomy has been done or not. Multiple things have been shown, but still it has shown that adjuvant treatment still improves the survival. So radiotherapy was also reported effective for local regional disease control based on its use, and adjuvant radiotherapy was assessed in 2 large trials. It showed some benefit earlier in the later trials, but not in the earlier Halsey and the Bleberg trials. So this is one of the main trial which established the role of adjuvant chemoradiotherapy in gastric cancer. In this particular intergroup trial, they have taken patients who had a curative resection of gastric cancer, observation alone or adjuvant CTRT based on 5-FU combination. So they gave 1 cycle of 5-FU followed by CTRT along with 5-FU, and then 2 more cycles of 5-fluorouracil. 5-year OS was significantly longer after CTRT rather than surgery alone. Around 10 months benefit was there. Similarly, in the progression-free survival was also significantly better, and at 10 years there was an disease-free survival and OS survival which was maintained even after that much long follow-up. So based on this, US has accepted that CTRT is the standard care of treatment in the patients, but there were multiple drawbacks, that only 10% of the patient had a D2 resection, which is considered standard at that time, and even more than 50% patient had a less than ideal D1 resection, and around half of the patient had a grade 3 or higher toxicity. So it was not easy to give treatment to these patients, and RT benefit was observed mainly for a role as compensating for the inadequate surgery which was done in most of the patients. So that's why it's not still accepted as a standard care in other parts of the world like India, Asia or Europe. So one of the other trial like LGBT trial, which showed that assessed the combination of ECF with post-operative CTRT, and they similarly showed that there was no absolute benefit of adding CTRT, and chemotherapy has almost similar rates. Similarly, there was an artist study in 2012, a Korean study, in which they compared whether we can give adjuvant chemotherapy or not, or versus adjuvant chemoradiotherapy. So in this, they compared adjuvant chemo versus CTRT, and they showed that there was not significant difference whether either you just keep chemo in the adjuvant setting post-surgery or give radiotherapy as well. In the subgroup analysis, they showed that the nodal disease patients had a significant benefit CTRT, so maybe for nodal disease patients, CTRT is preferred. But the follow-up trial, which is still not here, it showed that the ARTIST-2 study in which they have taken only nodal positive patients and they compared CTRT versus chemo. So they showed that there was not significant difference between chemo and CTRT. So still the standard of care, whatever evidence we have, is chemotherapy. So in the multivariate analysis, either of the arms, there was significantly prolonged DFS after adjusting for stage with some sort of adjuvant treatment rather than giving no adjuvant treatment. So I had already told ARTIST-2 study result. And similarly, the critic trial, which has shown that adjuvant, if we give a neoadjuvant and adjuvant chemotherapy, its results are equivalent whether we give radiotherapy or not. So adjuvant chemotherapy, one of the available strategies, particularly for the patients who didn't undergo proper resection. So regarding adjuvant chemotherapy, perioperative chemotherapy is not always feasible because patients are often referred to the medical oncologist only after surgery. So that's why most of the patients eventually receive adjuvant chemotherapy alone. And the use of radiotherapy is also not possible because patient's general condition doesn't apply us that we can use radiotherapy in this setting. So similarly, this meta-analysis showed that from 17 randomized trials, there is a significant improvement in overall survival and disease-free survival. You give some sort of adjuvant therapy, either radiotherapy or chemotherapy, but chemotherapy is the preferred thing. So 5-year survival was almost increased by 10% with the use of therapy. And the same is applied to most of the subgroups in this study. So one of the more study regarding ACTS-GC study in the Japanese population, in which they compared the use of S1 and another oral fluoropyrimidine, where the role of its S1 post-surgery compared to chemotherapy. An interim analysis showed significant difference in both the arms and significant 3-year survival benefit as well as a relapse-free survival benefit of almost 10% with the use of this particular drug. So similarly, this other study, classic study, in which they have compared the use of adjuvant capox regimen versus observation alone, and there was a significant around 15% benefit in the relapse-free survival, and there was a significant difference in overall survival of 5% at 5 years. Similarly, a trial going on is SEMIT trial, in which they are comparing uracil tegafor or S1 sequentially with chemotherapy or either alone, and this will help us to define whether taxanes have any role in the adjuvant setting or just we can give oral fluoropyrimidines. So these are the table shows most of the major trials which have established the role of adjuvant therapy, like the intergroup trial which established the role of CTRT in adjuvant setting. Other are ARTIST trial, critic trials and MAGIC trial, which initially showed the role of adjuvant treatment, either just surgery is more than enough or not. So recurrent disease, almost 50% of patients will have some sort of recurrence despite all the treatment. HIPEC has been tried, but not that much benefit has been found other than in some retrospective studies, but still a controversial thing to do. So regarding ESMO guidelines also shows what we have already discussed. So regarding now the advanced disease, almost 80% of patients will have advanced disease, 30% will have advanced inoperable, and 30% will have some metastatic disease at presentation. So survival of these patients is very poor, of around 12 to 15 months. So they are given some sort of chemotherapy, but the role of CTRT in this particular subset is not known. And metastatic disease has even worse survival at around 10 months, and palliative chemotherapy is shown to be superior to best supportive care, benefit of around 7 to 8 months. But we have to think of multiple things like performance status, comorbidities and organ function. So standard of care is platinum and a 5-FU based doublet regimen. Combination therapy has shown better results compared to single agent. Around 2-month benefit was there, but response rates was almost double and was significantly PFS difference was there. So triplet combination has also been tried. It has shown that the addition of the third drug also improves overall survival, though less of just 2 months, but there is significant increase in toxicity by using the third drug. So irinotecan versus non-irinotecan containing regimen trials have also been tried, but irinotecan has not shown that much benefit on overall survival, but though increased response rates were there. Docetaxel regimen has definitely shown a better response rates compared to adding with capecitabine and platinum. Similarly, this Cunningham and trial real 2, we showed that triplet with ECF has one of the best response rates. Patient second line therapy rarely progresses, and we have very less therapy for subsequent treatment.